and keep it free to use for students and staff. To do this, we have launched a fundraising appeal to help keep all of the 8 wonderful maternity and midwifery festivals free. Keep the weekly Maternity and Midwifery Hour and the weekly newsletters free to midwives and maternity staff. You regularly tell us how much you value these free resources, so do give what you can.
I'll do anything to pull you into the light, 'cause everything will change when you open your eyes. Yeah. So don't you let the sunlight go by without you. Don't you realize how lucky we are? Open up your heart, baby, let it all go tonight. Lift your
Welcome to the Maternity and Midwifery Hour. My name's Neil Stewart. I'm the editorial director of Matflix and the Maternity and Midwifery Forum. This is episode 1 of series 14 that we've been running really since the first day of COVID. Some of you will know already that as soon as COVID hit and everything was shut down, we decided that we would go online and provide regular updated information to maternity and midwifery professionals. And even though COVID has ended, this has proved very popular and we are carrying it on. This is the first episode of a new series that has a new government and time for change. We heard today from Wes Streeting, the new Secretary of State, that they're going to do a big plan for reform in the NHS, and we're going to hear all about it in the spring. So everybody needs to sharpen their pencils and get their solutions to all our problems out. Sue MacDonald is not with us this evening, the usual editor and curator of these programs, but we'll hear from her just in a moment. If you're watching online, the two speakers that we have were recorded at yesterday's big festival in Bath, where we had a couple of hundred midwives in attendance, another couple of hundred online, and the box set for that will be available shortly. It was an absolutely fascinating day with some tremendous presentations, and you'll find them all in Matflix. Matflix is the catalogue of over 1,300 presentations at lecturer level, suitable for revalidation. You should find them on your university library resources if they've subscribed. If they haven't, give them a prompt. It's just the kind of material that's needed in these days when every other kind of training or keeping up to date is being restricted. Over the coming year, between the Maternity and Midwifery Hour and our festivals, we'll be adding over 200 lectures to the catalogue, all of it very up to date and very topical, and just the kind of thing you need for your professional development. If you want to put information into the chat today and say where you are, we won't be taking any questions, but there will be information in there. And if you do want to leave questions for any of the particular speakers, to get a reply. So if we can just take a moment and let's hear from Sue MacDonald from yesterday's festival at Bath Racecourse, which apparently was lovely. Over to you, Sue.
Hi everybody, and it's been a very busy day. This is Tuesday the 17th of September, and we've just had the Wales and South West of England Maternity and Midwifery Festival, which has been fantastic. I should say my name's Sue MacDonald, and this is the Maternity and Midwifery Hour presentation, and I just wanted to highlight how fantastic the day's been. We're having a slightly different Maternity and Midwifery Hour tonight. We've just picked out a couple of videos to play, and also Neil Stewart will come along and give you some updated snippets of news for you. And I just wanted to kind of share my feelings about the festival today, which has been fantastic. It's been in Bath, and we've been at the racecourse, and all I can see now is the green of the run for the horses. There's no horses though, so the only scampering about has been by the midwives and student midwives. We've had some super midwives and student midwives participating. There's been lots of buzz and discussion and catching up and networking, and we've had fantastic presentations from subjects from historical midwives to water birth to hyperemesis gravidarum to preeclampsia and safe learning environment charter. And we've had the fantastic Trailblazer Awards for some superb midwives who are doing very exciting things, and a superb exhibition with lots of goodie bags and little samples of things and lots of information. So if you would like to come to the next festival, it's in Edinburgh And you can always join online, but also face-to-face is fantastic. So enjoy this evening's session, and I'll see you next week.
Thanks very much, Sue. And just to emphasise that the next festival is in Edinburgh. It's at Murrayfield. We do like sports grounds, mostly because they have beautiful facilities and they've got tremendous parking and usually very, very good connections. And they're empty for large parts of the year. So if you want to come to Murrayfield at the back end of November, just go on the Maternity and Midwifery Forum site, sign up to attend. It's free. We've got a tremendous list of speakers already. But if you're anywhere in the UK or internationally, of course, you can watch it online. So 5 or 6 or 7 times a year, you'll get a festival that's full of topical material, and you'll get the box set, and you can watch it live or you can watch it afterwards on catch-up. But we'll also be sending material out. And on that subject, on the 13th of November, we have 2 events running in parallel. One, the Midwifery Student Festival, which is being broadcast from the University of Leicester. And in a separate lecture theatre, we have the Future of Midwifery Education, which is for lecturers and for those making policy on midwifery education and all its developments, and also how the placements and other things are run in trusts. Both of them are free to attend and they're free to watch online, so get signed up. There's also a facility for universities and trusts to set up what are called hubs, in other words, a seminar room or a lecture theatre to watch it as a group. And that's become a very popular way of enjoying the festivals and partying. Setting up a watch party, you order the donuts, we join you up through Slido so you can ask questions to all the main speakers, and you get the full day's experience. And all of it's done at a level that counts for part of your education or your CPD or your revalidation. And I'd just like to thank all the LMEs and others who've supported this idea. It's much more practical than people rushing all the way around the country. But if you do want to attend at Leicester, then attendance is free. You just have to make your own arrangements to get there. So normally we ask for a moment of the week, and I had a moment of the week this morning. I went to the launch of the Institute of Public Policy Research's big programme on the future of the NHS as an asset. But the moment was that the very first question from the Sky reporter to Wes Streeting was on the future of maternity services. When was he going to meet Donna Ockenden? And I thought that was very interesting in the midst of everything else that's going on. Maternity services are likely to be at the top of the agenda, even if there are no easy answers. I'm also watching, and this sounds a bit grim, but I'm also watching the Thirlwell inquiry into Letby and what happened on the neonatal units, because a lot of that kind of fear that's been expressed by neonatal nurses and a worry about people being blamed for things that go wrong in their unit is, of course, also common to maternity units. And many of them have been through quite a difficult time. So the public inquiry that's going on there is likely to have lessons that cross over, not just neonatal units, and we'll all be watching that carefully. Matflix is up and running. If you don't have it in your university and trust, ask them why. They can take out the subscription, it all gets set up, you access it for free, and it allows you to add it into both your courses and for anything you need for revalidation. If you don't have direct access to it, you can now get access to Matflix for £35 a year, which I think is about £2.95 a month. So probably slightly less than the cost of a cup of coffee every month to keep yourself up to date. So I think that's enough for me. We have 2 really fascinating presentations this evening. The first is from, and these were recorded at the Bath Maternity and Midwifery Festival. The first is from Dr. Anita Banjari. She's an obstetric physician and diabetes and endocrinology consultant at Guy's and St Thomas's Hospital NHS Foundation. She has published articles, guidelines, and book chapters on a wide variety of medical conditions in pregnancy. She's one of the leading authors on the RCP's Acute Care Toolkit on managing acute medical problems in pregnancy. Her main interests are in high-risk pregnancies and the management of deteriorating pregnant women and education. But our topic here this evening is team working to manage care for women with preeclampsia and eclampsia. So over to Dr. Anita Banjari.
Okay, excellent. So I've only got 20 minutes, so shout out when I've only got 5 minutes left, so I give everything to you. But I think we need to understand the scope of the problem. We need to understand the definition so we're all on the same page. And then we've got to understand what the gap is so we know how to fill it, okay? We had a really interesting conversation this morning, and I enjoyed this morning's sessions about how you feel, but it's about how we feel and we bring it together. And I think that's what I hope I provide with you, with some solutions that we can take together. So Embrace, 1952, we're very lucky in this country. We've been looking at the maternal deaths in this country since then. We know the numbers have reduced, but it hasn't really budged in the past 20 years because of the change in obstetric landscape. The next Embrace report will be on the 11th of October, and in 2025 we'll be talking about preeclampsia. If you look now on my left-hand side at the bottom, you'll see the maternal deaths in this country. So to remind you, because I'm sure you all know that the dark purple are the indirect deaths, i.e. the medical problems in pregnancy, and the hatched ones are the direct deaths, i.e. the ones that happen in obstetrics because of things like postpartum hemorrhage, obstetric anesthesia. What I can tell you, having been a doctor for more than 25 years, is that your skills and drills in your maternity units are phenomenal. When you've got cord prolapse, when you've got PPEC, you know exactly what to do, when to do it, how to do it. What we've got now is that changing landscape and the medical problems, and then this actually does, make it a bit more complex. And how do we then work together? Because really, as you know, it's the tip of the iceberg. In the last time when we reviewed the maternal deaths of preeclampsia, there were 8. No woman should die in this country of preeclampsia. No woman should die of it. We should be able to recognise it, deliver, and make sure that the outcome is as good as it should be. Because unfortunately, as you both know, we cannot ensure that every baby is going to survive if they've been born too early. But more importantly, the morbidity associated with preeclampsia is striking. And as you know, worldwide, every 2 minutes a woman dies. 99% are in low-income and middle-income country. But you and I both know of every single maternal death that we may have been with in the past 20 years, myself and you. So, what am I trying to say? What I'm trying to say is that looking at Embrace, we can look at many reports, and we know the things are changing. So it's psychosocial, physical. You've got mental health, you've got the physical issues, and you've got the social aspects of the fact we live in austerity and the world has changed. Embrace identified reports when we looked at it in more detail of why is it that for preeclampsia, I'm really now concentrating on preeclampsia, what's happening, what is wrong. Where are the challenges in our communication and our leadership together, and how does this contribute to maternal death and to morbidity? And the 3 factors that we all know about, whether it's the Ockenden report, whether it's the Better Births, or all the reports that may have happened locally, regionally, nationally, it really is early recognition of something that's happening. Second, the prompt involvement of the right people, right senior midwives, obstetricians, and occasionally the obstetric physician. And multidisciplinary working. We've got to work together. So what is preeclampsia? And really, the definition of it has really changed, I would say, in the past 20 years. Okay, we do know that you have to have high blood pressure in the second half of pregnancy. Okay, we do know that you can or cannot have proteinuria. Proteinuria itself is not a diagnosis of preeclampsia. So don't think just because you've dipped the urine and the protein is NAD that she hasn't got preeclampsia. I love preeclampsia because it's a fantastic disease, okay? I'll be honest with you, the reason I'm a physician, obstetric physician, is because to me that's at one stage in a woman's life where she has accelerated atherosclerosis, she's as sick as she can be, and guess what? The placenta comes out and she's all right. Tell me about it. What else? What other condition in the world does that? Nothing. Okay. So I find that really fascinating, because if you look at the end organ damage, and these are the blood tests that the obstetricians do, the platelets, the renal profile, the liver profile, okay? But you guys have already seen the woman, and you've already decided she's got preeclampsia, and you don't need my blood test, yes, to confirm it, but let's work together. And remember, also with preeclampsia, it can be obstetric syndrome, i.e. the baby's not growing, growth restriction. So can you see that definition is far more robust now than it ever has been? But do we all have our silo thinking, fixation on something? Yes, no proteinuria, can't be preeclampsia, not worried. We've got to change our mindset, because our women are changing. Placenta growth factor, anyone heard of it? Who's using it in their hospital? Can you shout out which hospital that is? Okay. Bath. Anywhere in Wales? Not yet, okay? Because 95% of England use placenta growth factor, okay? You'll be pleased to know, with all the leadership of Marcus, I believe that we're going to have placenta-like growth factor testing in Scotland. But what are we doing in Wales, and where are we doing everywhere? Because what are we doing all the other hospitals? Preeclampsia, subjective, objective markers, and you haven't got a test that has been around since NICE have said it should be around in 2016. So what is placenta growth factor? Okay, it's a blood test that you can take. So it's a free concentration that you can take between 22 weeks and 35 weeks. Why do we measure it? So if we think about the placenta and that connection between the mum and the baby and that placenta growing, you need angiogenic markers. You need things changing in your blood vessels, in the syncytium, in the placenta, to work properly. We know in the first half of pregnancy, if the spiral arteries are not happy, you've got a higher risk of preeclampsia. And the second half of pregnancy, if these growth factors are not in equilibrium, they're not happy. And you can see from the left-hand side, my left-hand side at the top, the figure, normal pregnancy, okay, you've got the angiogenic markers, the PLGF and the S-FLIT happy. When you've got preeclampsia, you've got an imbalance of this, and the placenta growth factor is low, and therefore the blood vessels do not work properly, and you've got placental insufficiency. So wouldn't you love to have this test? Yes? Yeah. Because if it's less than 12, it's a no-brainer. She's got preeclampsia, and in this country you would, expect that she will be delivered in the next 2 weeks, and it's someone that we need to keep an eye on or possibly admit. If it's greater than 100, you're not worried, you've thought about it, but you can actually discharge her. And then the 12 to 100 is my world. It's that risk stratification. How often do I need to see her? What do we need to do? And what is the right thing to do at the right time? So, how do we approach the pregnant woman with preeclampsia? We're all working our silos. You mentioned this morning the obstetricians and the midwives. Include me, include critical care, the ambulance service, the GP and the nurse, and everywhere else that our women pitch up. Really hard, yes? But we've got to work together, because we know there's guidelines, yes? We have those guidelines. But how do you maintain guidelines, and who knows about it? And it's all about flatten the hierarchy. So multi-professional working, to me, is interprofessional and intra. Know your department, flatten the hierarchy and bring it together. And then more importantly, your woman will present in the accident emergency with the GP, upskilling them, because do they know about placenta-like growth factor? Do they know about the fact you don't need proteinuria and you can still have preeclampsia? These are really important things. So some of the ways you can learn, and today is a brilliant example of that, study days, e-learning, webinars. Which one's your fancy? Anybody? Yeah, you see, it all depends. You've got to be in the right place at the right time. Your headspace has to be there. So, study days. Action on preeclampsia, very proud to be a trustee of it. And we have study days for preeclampsia. So we have actually go across the country teaching and upskilling people to remind them of all the different aspects of preeclampsia. Days like this is a brilliant example. You're very close to Bristol, so you've got Prompt. I mean, every single one of you, I hope, uses Prompt, because it's a fantastic multidisciplinary training day. But how much do we put in with preeclampsia, or do we all think we know everything about it? I would go back to your own trust and look at that. And then all our colleges, you've got your Royal College of Midwifery, you've got Obs and Gynae, and anaesthetics. I haven't even put my college, the RCP, But do we work together? Do we actually have training together? Tell me what the last time you've been to something where we've all felt welcome. Excellent. Brilliant. And I totally agree with you. So that's in regional and local, yes? But let's make it more national and international. So e-learning. E-learning is a great way. I think COVID taught us a lot, that we spend a lot of time on our computers. And when you've got the headspace, you can do this. So the multidisciplinary approaches to health is on the e-learning NHSE. It was first built in 2014 for medical SHOs. In 2020-21, we upskilled it. And then we actually realized, we needed to do it multidisciplinary. We needed to make sure midwives, obstetricians, and medical doctors could look at it. And interestingly, when we pulled which one, because it's all maternal health, i.e. respiratory, endocrinology, the one that everybody was looking at was hypertension and cardiovascular. So you can see we all want to know more about preeclampsia and cardiac disease. If we think about simulation, who likes going to a simulation? I'm not talking about prompt, because prompt is quite a safe psychological support for skills and drills. But what about other simulation days? You're all smiling. You like it? So there's 2 of you that like it. Okay, 3, okay. I love simulation, okay? It can be part task, it can be in situ, it can be in a whole day or half a day. And I want to share with you something that I started about 10, 15 years ago, where we got a bid and looked at simulation for South East London. And we've actually now had more than 35 training days on it. And it's called MEMO, Medical Emergencies and Obstetrics. But what was really interesting is that when we looked in detail about the behaviours of us as midwives, obstetrician, anaesthetists, because we'd have 16 in half a day, we would have 8 midwives, and the other 8 would be doctors, specialists from A&E, obstetricians, all coming together. We'd have 3 scenarios. It would, for instance, it would be subarachnoid hemorrhage, preeclampsia, and asthma. And then we would actually film and understand it. And later we would look at this recording and understand our behaviours. And what was really interesting, and I wonder whether this mirrors how you feel, that when you had a good outcome in a simulated scenario, the ones that worked well was when right at the beginning you were all on the same page. You were all working together doing something. The time when the outcome was poor clinically was when the doctor came along and just delegated all the jobs, didn't listen to the midwife, and everybody then was working in silos and not working together. Does that mirror how it feels sometimes on the shop floor? And I think this is really interesting about getting it right at the time, as soon as you turn up to a medical emergency, how we work together. That actually influences every single one of us. And what we found in this, particularly for the medical deterioration, is who's leading the team? Are you co-leading at times? It should not always be the most senior doctor or the most junior doctor. It should be a midwife at something, because everybody's a leader. Everyone has a voice and can co-lead. Secondly, developing the shared mental model. Not just thinking it in your head, speaking aloud and having the opportunity to speak aloud, so we're all saying the same thing at the same time. And then requesting and providing assistance, i.e. follow through and close communication. I'm not telling you anything that you already know, but what I'm saying to you is that when you are in that stress situation, when you're not in that normal skills and drills of a PPH or a shoulder dystocia, how do you come together to gather the information, understand it, and talk aloud? So what have I explained to you about multidisciplinary teaching and training for hypertensive disorders and preeclampsia? So if we start at the top, aspirin and pre-ET prophylaxis. So antenatally, before 16 weeks, you've got to identify that they have a risk of preeclampsia. The only prevention we've got is aspirin, sadly, in this world. I do hope we have something else in my lifetime, but I don't know. But we've got to give it at the right time, yeah? So we've got to identify it. So that's all of our problem, yes? It's not just the doctors or the midwives or the GPs. When is the aspirin given? Then if we go to the left-hand side and we go to that table, it says severe maternal morbidity. So remember, this is why women are dying worldwide and in this country of preeclampsia. They're getting eclampsia, pulmonary edema, HELP syndrome. Are we recognizing these things? Are we using the tools that we have? Are we doing the tests at the right time? Or is this a virtual consultation and the woman is not actually coming into the hospital? Once we've diagnosed it, do we use the magnesium for the right reasons, whether it's neuroprotection, preventing eclampsia, or prophylaxis for eclampsia, or treating eclampsia, and getting the drugs right? So imagine if you were on ITU and you've got somebody who's got a preeclampsia. Do you really think the intensivists understand preeclampsia? You know it much, much better. You know you want the blood pressure less than 140 over 90 in ITU or in A&E. So you have to be the voice. It cannot be the junior SHO going up there. You guys have so much more experience. You will understand this and start talking to each other. Maternity early warning score system. Is anybody using the new Muse at the moment? Which hospital is that? Excellent, yeah, so are we at Tommy's. But we should all be using it, hopefully, in 2024-25, once the digital spec is out. And I would say that this is going to help us help hypertensive disorders in pregnancy, because as we know, it's from conception to 4 weeks. I know it's too far away for you to see it, but we should all be more familiar with it. But more importantly, blood pressure. If the blood pressure is high, i.e. above a 140/90 in the first half of pregnancy, finally an A&E doctor or GP or somebody might come to you and say, you know what, I'm a bit worried this blood pressure is a bit high, because you might then treat it. If you treat it in the first half, that placenta is going to be much happier in the second half, and we may have a baby that's not preterm, or more importantly, we have a really good outcome. So I think we should use the Muse, and we should use this as a reason for improving our relationship with the rest of the world about hypertensive disorders in pregnancy. Clinical tips for preeclampsia. Have any of you seen this? This is the quick reference guide for obstetric emergencies, made by the OAA. They got an award in the HSJ in Manchester award last night. Commendation. They didn't win the award, but they got a commendation. But it is fantastic. So if you look up quick reference guide, it has this for preeclampsia. And if you actually take this to your A&E, acute medicine, your poor junior doctor, you know, the F2 or the VTS trainee, you know, and you show it to them, look, this is how you treat preeclampsia, and you know what to give when. This will help them, and it will help you. And I hope it will help the student midwives too. So please look at this. New horizons and next steps, faculty development. We've got to develop a team across maternity and all the other settings outside of maternity. Okay? We've got to work and train together. So I hope one day we will do this again, but we'll have the obstetricians and we'll have the medics here as well for half a day. You don't need them the whole day, but you can have them for half a day. And we need more research in understanding how we communicate, because we talk about culture and a change in culture. I don't think it will happen in my lifetime. We've got to understand how we're going to change that culture and work together to really, really sort it out if we want our children to have a better outcome and their offspring. So mind the gap, work to bridge the gap, and let's remain patient-centred for the rest of the day. Thank you.
Absolutely fascinating. And a big shout out for Wales and Scotland to catch up in their provision of multidisciplinary training. I must admit that one did catch me by surprise. I did think that this was something that was quite common. We've had the details of action on preeclampsia and their link put in the chat. So if you want to follow up with either Anita or get in touch with Marcus and co from Action on Preeclampsia, then just follow through that link. But really a fascinating presentation. And for those of you who've been through the multidisciplinary processes of PROMPT, you'll know perfectly well how important and how successful a development all of that has been. Okay, so that was one of the presentations amongst many, a fascinating day out in Bath. And as Sue mentioned, there was also a presentation from Billy Hunter on a history example of following a midwife who started off as a general sort of handy woman, is what they were called before the original legislation to recognise midwives, who then became a midwife and then carried on and was still working well into her 60s in the early days in South Wales. And just seeing what her life was like and the cases that she was treating and the notes. And it all came from discovering a notebook of all her cases, which was very nearly thrown out. And that was really fascinating. Plus, there's a presentation on water births and the pool study, which again had the audience enraptured. But we're now going to go on to the second of the presentations we have picked, which is from Dr. Melanie Nana, who's an obstetric medicine fellow at Guy's and St. Thomas's. She moved to London in 2020 to undertake a clinical obstetrics medicine fellowship, during which time she was taught obstetrics medicine by Professors Catherine Nelson Percy and completed the Royal College of Physicians credentials in obstetrics medicine. She has several publications related to obstetric medicine, including the largest study to date determining the lived experience of women who suffer from hyperemesis gravidarum, the results of which were featured on the BBC News. She's the author of the recently updated Royal College of Obs and Gynaes Green Top Guidelines on Nausea and Vomiting and the European Guidelines for Liver Disease and Pregnancy. She's currently working on her PhD. And she's going to give us a talk on the management of hyperemesis gravidarum. So over to Dr. Melanie Nana.
I'm going to talk about nausea and vomiting of pregnancy and hyperemesis gravidarum. This session is sponsored by Exeltis, but I'm going to give an overview of hyperemesis, nausea and vomiting of pregnancy, touch on the recently updated RCOG guidance, and then talk a bit about some of the medications in pregnancy that we use for this condition, as well as Zomvir. So, as mentioned, I'm one of the authors of the recently published RCOG guidance on nausea and vomiting of pregnancy and hyperemesis, and my PhD focuses on, firstly, the nutritional status of women with this disease, and secondly, how we can try to improve care for all women who suffer with it. So, as people who look after patients who are pregnant, you'll all be familiar with nausea and vomiting of pregnancy, which affects between 80 and 90% of the pregnant population. It starts very early in pregnancy, often before we meet these patients in secondary care, and typically peaks 9 to 10 weeks and then settles down in the majority of patients by 16 weeks gestation. The sickness is different for different patients. We know that the majority of patients, so 99%, will experience nausea, just under 75% will have vomiting, and about half dry retch. Previously, this condition was known as morning sickness, but we now have good evidence to suggest that the symptoms are not seen just in the morning, but throughout the day. So what's the difference between nausea and vomiting of pregnancy and hyperemesis gravidarum, or HG? Well, hyperemesis gravidarum describes the very end of the spectrum of the most women with the most severe disease. So this is 3.6% of the pregnant population. And what's important to recognise for these patients is that 1 in 5 of them will have symptoms throughout their whole pregnancy. So we expect in most cases of nausea and vomiting of pregnancy symptoms to improve by 16 weeks, but 1 in 5 women with HG will suffer into their 3rd trimester. I've put here the international consensus definition, which we have incorporated into the recently published guidance. This was published by the group in Amsterdam, who brought together international experts to try and determine a definition that would ensure that as many women as possible get the right diagnosis and access to appropriate care. So they recommend that symptoms of nausea and vomiting, one of which must be severe, starting before 16 weeks gestation, with the inability to eat or drink normally, and symptoms that strongly limit daily activities, if women meet this consensus definition, should have a diagnosis of HG. So when we talk about vomiting of pregnancy and HG, it's quite difficult to ensure that we're using a similar way to try to determine the severity of these patients. And this is really important because we know that we see these midwives see these patients. They might come to the early pregnancy unit, they might go to their GP, they might attend the emergency department. And so if we're all using the same sort of severity score, it can help us determine how that woman's progressing, as unfortunately they tend to bounce between services. So this is the puke score, which determines whether a patient has mild, moderate, severe, or very severe disease. And it's determined using the number of hours that that woman feels nauseated throughout the day, or within 24 hours, the number of times that they vomit in that time, and the number of times they dry retch. And if they have a score of over 13 out of 15, that's considered severe NVP or HG. And this is useful not only in our clinical settings, but also in a research setting to be able to determine whether there's been improvements if we, for example, try a new interventional drug. So when it comes to the clinical assessment of these patients, what we've determined in the guidance is that in order to be able to confirm a diagnosis, patients should have a typical history of nausea and vomiting of pregnancy, which we're all familiar with, but that we should also rule out some other common causes of nausea and vomiting to make sure that we don't miss those patients who perhaps are presenting with high blood glucose levels. Perhaps they're in DKA, rare cases, or they have a urinary tract infection and that's causing the nausea and vomiting. So what we've suggested that is in all patients presenting for the first time with severe vomiting in pregnancy, that they have a urine dipstick, not to look at ketones, but to look for signs of infection, so nitrites or leukocytes, that they have a full blood count, again, to look at the white cell count, signs of infection, a glucose level to look for hyperglycemia, because diabetes can contribute towards nausea, vomiting, and in severe cases, women who develop diabetic ketoacidosis can present with vomiting, and we mustn't miss that, and abnormal urine needs. So this would suggest an acute or chronic kidney injury, which again can contribute towards nausea and vomiting. It's recommended that all of these patients have an ultrasound scan to confirm a single intrauterine ongoing pregnancy, because we know that patients who have twin pregnancies, for example, have increased risk of developing this disease. So we'd like to know about that early. Now, if all of those simple investigations are normal or reassuring, then we can assume that the patient has the diagnosis of nausea and vomiting of pregnancy. But what we've suggested is that we refrain from doing these additional tests unless the patient isn't behaving how we might expect them to. So we've suggested that in refractory cases, so patients where an antiemetic, 1, 2, or 3 antiemetics have been started, the patient is improving, or there's something about the patient that makes you think this isn't quite right, then we should go on to do these additional tests. And the reason that we're doing this is to be able to rule out differential contribution towards screening. We know women are entering medical conditions, but there are also more patients presenting with medical pregnancy. So I went through each of these, but as an example, there was a patient that we looked after at St Thomas's who presented who didn't quite fit the typical history. Her main complaint, as well as the vomiting, was severe epigastric pain. It didn't help when we gave her some omeprazole, and she'd lost a significant amount of weight. And we treated her with antiemetics. This didn't improve her symptoms, so we stopped them, and well, we didn't stop, we continued them and requested an endoscopy, and she had a gastric malignancy. So these are very unusual and rare causes, thankfully, of vomiting in pregnancy, but we've just got to use our clinical judgment to be thinking, are there any patients that we're looking after that don't quite fit the right fit? And so we should consider doing additional tests. These include thyroid function tests, liver function tests, a calcium phosphate, amylase, and to look for pancreatitis, and an ABG or a VBG to look for metabolic causes. So this is a busy slide, but I just wanted to show it because I think that it helps us understand all of the different ways that this disease can affect a woman. It's a multi-system disorder, and if we are able to think about it as such, we're able to determine how we can best treat the woman, because each patient that presents will be slightly different. I'm not going to go through all of these points, but I want to highlight gastrointestinal symptoms, because we know that the second most common symptoms in women who have nausea and vomiting of pregnancy, or HG, is that of reflux disease. This can be very severe, and it's particularly if women aren't eating very much, they're kind of vomiting multiple times. Acid reflux can cause gastritis, or in worst cases, esophagitis. So we know that we can prescribe proton pump inhibitors in pregnancy, and this is often a very useful part of the management. I wanted to mention liver enzyme disturbance because women will often come into hospital and they can have a routine set of blood tests, or in patients who have severe disease, we might intentionally send liver enzyme disturbance tests off. But we should recognise that in up to half of the women who have this disease, they will have a raised alanine transaminase, so an ALT. Other women can have a raised ALP, which we know, of course, can happen in pregnancy anyway, bilirubin or amylase, and this can just be part of the disease because the disease causes a state of starvation, which can cause abnormalities in the liver enzymes. So when we were writing the European guideline for liver disease in pregnancy, we were asked by the liver specialists, can you include this disease? Because we get lots of referrals for abnormal liver function tests, which turns out to be HG. So what we recommended is that if the liver function test, whatever it may be, ALT, albumin, bilirubin, is less than 5 times the upper limit of normal when the woman is vomiting, we can assume that it's related to the disease. We will treat the disease with anti-sickness medications and and then repeat the blood test. And only if it's not getting better, we would then refer on. Of course, in caveats in medicine, if you're worried about the woman and there's some symptoms that you think aren't quite in keeping with HG, then refer them anyway. But it's something to be aware of. We know that there's an increased risk of venous thromboembolism in these women. It's 2.5 times increased that of women who are pregnant otherwise. And we would recommend using the RCOG guidance to determine whether they should be given VTE prophylaxis. We recommend that all women admitted to hospital should be given it, but also they should be given it in the community if they score 1 for having hyperemesis in the first trimester or second trimester, but they have another risk factor, whether that is raised BMI, whether it's immobility, or other things that feature on the RCOG guidance. So if you score 2, then we would recommend that in this circumstance, they would have VTE prophylaxis earlier on in pregnancy. These here, vernicase encephalopathy and arrhythmia, central pontine myelinitis, and acute kidney injury are more severe complications of the disease. Vernicase encephalopathy results as because of thiamine or B1 deficiency. In patients where they become starved significantly, low enough to have vitamin B1 deficiency, we know that half will lose their pregnancy, and some of these women will be left with residual cognitive impairment. In my opinion, this is preventable, provided that we prescribe thiamine or Pabranex or whatever vitamin B complex we use in hospital. So if patients have been admitted, we try to replace these vitamins. And if they're at home and they have continuous vomiting, we try and ensure that they're prescribed thiamine. Arrhythmias result from low potassium levels in patients who are particularly dehydrated and have acute kidney injury. And central pontine myelinitis can occur when a patient presents with low sodium levels because they've become very dehydrated and they come into hospital and the sodium level is corrected too quickly. So that can affect the osmolalities and the water shifts in the brain, which can cause cognitive impairment. So in terms of these complications, what we recommend is having, if patients are in hospital with severe disease, they should have a blood test every day to look at their urea and electrolytes. So checking the potassium, checking the sodium daily to make sure that it's not being corrected too quickly and that any low or high potassium is being checked. So they're the physical complications, but there are also a number of mental health complications associated with this disease. And this is a study that we did back in 2021, where we worked with the BBC and the UK charity Pregnancy Sickness Support to study all of the women who had suffered with HG. So the survey went out, and within 3 weeks, just over 5,000 women had replied. And some of the findings were quite distressing. 5% of these women had terminated a wanted pregnancy because of the disease. 6.6% of them experienced regular suicidal ideation. And these numbers are bad enough, but we know that a primary school teacher last year took her own life, and her family are now doing a lot of advocacy work. She was a lady who had no mental health problems but had struggled to access care. When she had been able to access an antiemetic therapy, she was inappropriately advised that she would have already caused harm with that medication to her unborn child. And she was very low in mood and very sadly took her life. So we've got a lot of work to do in terms of ensuring that all patients get good access to guideline recommended care. When we looked at the risk factors for these adverse outcomes, you can see here it makes sense that the more sick a woman is, the more likely they are to have a bad outcome. Those with poor functional status, so those who are bedbound, who can't look after their pre-existing children, who can't go to work and earn a living, really struggle. And those who experience poor quality of care, which again is very upsetting as a healthcare professional, because we're all here to try to provide best care for the patients. But those who feel dismissed, not listened to, really struggle with this condition. So to touch on the management, this is a summary of the RCA. And you'll be familiar with the first line medications. These are largely antihistamines that were present in the 2016 guidance. The second line and third line medications, so metoclopramide, domperidone, ondansetron, haven't changed, nor have steroids as third line medications. The difference is the introduction of Zomvia, which is a combination of doxalamine and vitamin B6 that I'm going to come on to talk about in a bit more detail in a moment. So some key points in terms of changes in the guidance is that it was recommended that if a woman is vomiting, we start a first-line antiemetic. If they're not responding, we add another antiemetic, because we know that they all work slightly differently. Rather than take for patients with reflux, we replace the thiamine, give laxatives if a woman, particularly if they're So the key changes, as I mentioned, on the mission to prescribe metoclopramide for more than 5 days, removing the use of ketones for the management of nausea and vomiting of pregnancy. And also, if you look at section 5 of the guidance, you can see that we've developed these treatment algorithms for primary care, emergency care, early pregnancy unit, and inpatient care to make sure that basically each algorithm kind of gives the patient the same care, regardless of which sector they end up in. I'm going to touch briefly on ketones, because we now recognise that patients are being denied the opportunity to get into hospital to have IV fluids and antiemetics because they don't have enough ketones. But we recognise that ketones were considered previously to be a marker of dehydration, but in fact they are a marker of starvation. So they're made when we haven't got enough glucose or carbohydrate, and we therefore break down our fat and produce ketones. So if we're concerned that a woman is dehydrated, so they've got dry mucous membranes, they're tachycardic, they're not passing enough urine, they shouldn't be denied access to hospital because they haven't got ketones in their urine. Okay, so I'm going to talk about 2 medication queries that we get asked often before I come on to talk about Zomvia for 2 or 3 minutes. So metoclopramide being prescribed for more than 5 days is acceptable as per the guidance. The reason that people worried about this, and particularly that EMA came out with a warning against it, is that it can precipitate extrapyramidal symptoms. These are movement disorders. However, when we reviewed the literature, this happens largely when it's given intravenously, and it happens in less than 0.2% of patients that are prescribed it. It occurs within the first 24 to 48 hours usually, resolves quickly if you stop the drug, and if it doesn't stop quickly, IV bentropamine can be used. So considering this is so rare, and considering all of the physical and mental health complications that we've discussed already, it was agreed in the guidance that on balance of risk, that it was worth continuing what is a very useful antiemetic for more than 5 days if patients are responding to it. What about ondansetron? Well, we're also aware of an EMA warning that suggested that ondansetron was associated with cleft palate. And there were 3 large studies done, one of which suggested that there may be an association between ondansetron in the first trimester and cleft palate. But what we have to recognise is this. This is the background risk of cleft palate in the UK population. So 11 per 10,000 babies will be born with cleft palate. If the 1 out of the 3 studies suggesting an increased risk of cleft palate with ondansetron is true, that risk goes up with ondansetron to 14 per 10,000. So that's a 3 per 10,000 attributable risk to the ondansetron. I use this figure, which is taken from the Irish Medicines Agency, but it's also now in the RCOG guidance, to show patients who are really suffering, I think they'll benefit from ondansetron. And in the majority of them, they're very happy to take this risk, or they are rather willing to take this very small risk so that they avoid all of the other complications that we've discussed. Okay, so I think I've got a few minutes left. So I'm going to talk a bit about Zomvia. So This drug was developed so that because it has a license for nausea and vomiting of pregnancy in the UK. So it's one of the very few medications that we use in pregnancy that has a license. It's been studied in 131 patients in a phase 3 trial. It's been prescribed in over 600,000 pregnancies in the UK and over 2 to 3 million across the globe. It's been particularly used in North America, Australia, and Spain. So it's a combination of doxalamine, which is an antihistamine, and vitamin B6 pyridoxine. And it's licensed for women over 18 years old who are not responding to conservative management for HG. So I'm going to show you 2 slides that look at the results. So we discussed the puke score before. And in the phase 3 study, what they found was that in the patients who were prescribed Zomvia compared to a placebo, there was a reduction in the baseline puke score between starting taking the medication and day 15 of taking the medication, so an improvement in 2 weeks. They also very importantly looked at quality of life, and they also demonstrated that the use of Zomvia was associated with improved quality of life scores. There was less time lost from work, which I think is really important in these women. In women who are financially well off, who've got partners that can support them, it's probably okay to take some time off work. But those women who are self-employed, who can't afford to lose their jobs, this treatment and other antiemetics can make a real difference. Interestingly, in the group that were prescribed Zomvia at the end of the trial period, 50% of them asked if they were able to continue the drug because they found benefit. What about the side effects? So the most common side effect that we see with Zomvia, and for those of you who've seen it prescribed, women have complained of, is that of somnolence. So it can be associated with this. Probably about 1 in 10 women will say that it makes them feel tired. This is very similar to the other antihistamines that we prescribe as first-line medications. So it's dosed at 2 tablets at night time as a starting dose. Then 1 tablet is added in the morning and 1 at lunch. I think that's very sensible because then patients are taking the majority of the dose at night time when they're going to go to sleep. In terms of warnings, because of this problem with patients feeling sleepy, it's not advised to take other CNS depressants alongside it. So, for example, benzodiazepines. And it shouldn't be used with monoamine oxidase inhibitors, which I think are predominantly, from my experience, used more in the elderly population. But these monoamine oxidase inhibitors prolong the anticholinergic effects of the antihistamine, so best to be avoided. That's what we've described here. We've discussed not prescribing with a CNS depressant. And in not small number of cases, it can cause false positive urine drug screens in some of these drugs that we screen for in maternity. So if you're prescribing or it's being prescribed and you get these positive tests, which is, you know, a small population, but it's worth being aware of this. We have a lot of data for pregnancy with Zomvia. It's probably the most studied anti-sickness medication in pregnancy for nausea and vomiting. So that's very reassuring. There are fewer data for breastfeeding, but it likely is that it will cross the breast milk. So say the woman gets pregnant again while breastfeeding a previous child, it's advised that we just look out for sedation in the nursing infant. Particularly if they have a respiratory system problem where they have breathing problems. There are no good evidence to suggest that it affects fertility, but these studies are only in rats, and I don't think we can extrapolate them, but there's no physiological reason that we would be concerned about fertility. Okay, so I'm going to stop here on my last slide, which outlines how we administer the drug. So like I mentioned before, for 2 days, you take 2 tablets at night. If this isn't enough, you get 1 in the morning and 1 at lunchtime. And the team at Exeltis have some of these, which I think are very helpful for the clinic to be able to hand out to the patients. Okay, it was a whistle-stop tour, so I'm delighted to take any questions. Thank you for having me.
Okay, thank you very much. Melanie, that was a fascinating presentation. I did watch it originally. And of course, the most famous sufferer from HG was the Princess of Wales in all 3 of her pregnancies. And that was a moment when a great many in the public began to discover exactly what the difference between what is described as morning sickness, which might be regarded as routine, and these much more serious conditions and consequences. So there's two presentations which focus on some of the most difficult aspects of midwifery care and looking after women through pregnancy and some of the biggest challenges. I hope you've found that interesting. This will also go out as a podcast a few days later and will then appear again in the Maternity and Midwifery Festival newsletter. And people can visit it on that site where it will be up for a period of time. And you can email and get back in touch with the speakers if you would like. So next week, Sue will be back, but we will be having a session on nurturing connections to strengthen breastfeeding support with three presenters, Dr. Anna Byron, creating coherence through connected leadership, Professor Jill Thompson on maternal and infant nutrition and nurture unit research, and Sarah Johnson will be sharing insights into the role of education in supporting and sustaining breastfeeding for staff and students. So remember, we've got the Student Festival on the 13th of November, and in parallel to that, the Educating Midwives for all the lecturing staff from the University of Leicester. Check out the Maternity and Midwifery Forum website and get signed up. If your institution doesn't have Matflix, you can now get it for £2.99 a month, I am told. Still less than the cost of a coffee. And keep yourself absolutely up to date. Get notice of all the festivals, all these programs, and the weekly newsletter. So I think that's enough from me. Sue MacDonald will be back next week, and thank you all for listening.
I'm Nicole Rajan Brown. I'm a proud midwife, and I'm proud to be supporting the Maternity and Midwifery Forum, who have helped me to grow, and for creating wonderful professional digital and online resources for midwives across the globe. The Maternity and Midwifery Forum ran their programs free and online all through COVID. Now we want to grow the catalogue, spread it worldwide, and keep it free to use for students and staff. To do this, we have launched a fundraising appeal to help keep all of the 8 wonderful maternity and midwifery festivals free. Keep the weekly Maternity and Midwifery Hour and the weekly newsletters free to midwives and maternity staff. You regularly tell us how much you value these free resources, so do give what you can.
I'll do anything to pull you into the light, 'cause everything will change when you open your eyes. Yeah. So don't you let the sunlight dim out without you. Don't you realize how lucky we are? Open up your heart, baby, let it all go tonight. Lift your
Maternity and Midwifery Forum brings you Matflix, video streaming from maternity experts. All your CPD and revalidation needs met.